Hi there. This is the first chapter from the Health Professional Educator book. This book is useful in that its ideas are for both training the trainer, kind of teaching coworkers, and also helpful in teaching patients. But the other book you have is more patient-oriented. During the 1960s and 70s, there was a real shift from a place where patients would just do what they were told to a place where patients were educated about their process and brought in to actively be participants in their health care. This is not really surprising if you think about what was going on socially, the upheaval that was occurring at the time, where the motto, at least of the feminist movement in the late 60s and early 70s, was "the personal is political." So this was a time when body autonomy and personal freedom was really at its height. They really felt like they were quite an enlightened society at the time. So it is not at all surprising that during this time, the late 60s and into the early 70s, we saw this shift in what patient education could truly do. And then it wasn't until into the year 2000 that there was enough research, enough number of years of research, where we saw that educating the patients and bringing them in as active participants in their healthcare made a difference in society. It meant less money that the insurance companies had to put out. It meant that the people who were later on Medicare were healthier, and therefore it cost the system, if you will, less money. And it was true that people became more savvy consumers. This was also about the same time that the internet really boomed and people were learning how to research their own conditions. So this is when suddenly people had the internet in their home. For the most part, before the early 1990s, there was no internet. And it wasn't until the mid-90s that it was readily available and people really began having it in their household. And it probably wasn't until somewhere between 95 and 2000 that the rest of us actually got the internet and everybody was using it on a regular basis. So because of all these things, we had more savvy consumers of healthcare, we had better access to information, and we had a lot of research that showed that having people involved in their healthcare made a difference. And so now we've sort of integrated it, and it's become part of our normal everyday life in the healthcare world. There's certainly a lot of benefits to educating everybody involved. When you educate patients, they tend to come back to the hospital less often. They have better quality of life, and all that stuff means that they spend less money on their health care. If you educate staff members, then they're more likely to do a good job educating patients. They're also less likely to get into trouble later on. So if you tell somebody, don't pull your pants down in a patient room, then they're less likely to pull their pants down in a patient's room. If you don't tell them that, there's always the chance that they'll do something stupid. So unfortunately, you gotta tell them, don't do anything stupid, or it costs everybody money. If you use a systematic, sequential, logical approach to educating people, whether it's a patient or a staff member, then you'll have better outcomes. They liken this in your book to the nursing process, where you have goals and then you have a plan of action, then you assess your goals, and then you start over at the beginning again. And change and make any kind of changes you need in order to make this all successful. The bottom line, you need two players. You need someone to teach and someone to learn. If you don't have someone capable of teaching, if you don't have someone capable of learning, then you don't have the pieces that you need for this to be successful. So that's part of the initial assessment. Is the person doing the teaching a good fit for the situation? Is the person doing the learning capable of learning? This is what I mentioned a minute ago. You plan something, you assess the needs of the patient, then plan how to get there, then implement that plan, and then reevaluate to see if your outcome was what you desired. So it's really the same process that you use when you're treating a patient for a medical problem. We assess the patient's condition, we figure out how to treat it, then we implement that treatment, and then we evaluate it. It's just like putting someone on a ventilator and then checking later to see if it actually worked. You draw some blood gases, make some changes, and in the end, hopefully, you'll heal your patient. At the end of this educational process, hopefully your patient will have learned something, changed their behaviors, and become overall healthier. And if you're educating your staff, then hopefully their behavior will have been modified, and you'll have better outcomes overall. This is basically a list of vocabulary words. What is learning? It's a change in behavior that you can observe, that you can measure, and it's got to be directly related to some sort of external process. So if someone just naturally learns, that's fine, but chances are they didn't learn in a vacuum. They probably saw something, heard something. At some point in their life, they were exposed to something that caused them to change their behavior. Patient education is a process of changing health-related behaviors. And of course, staff education is, as I said a minute ago, those are changes in skills in order to deliver better quality or higher quality health care to your patients. For learning to be intentional, it has to have deliberate information sharing between one person and another. Not all learning is deliberate. Infants, children, they learn language not really deliberately. They just sort of absorb it from their environment. So that is learning, but it's not necessarily intentional learning. There's a lot of affective behaviors, which I'll talk about in a minute exactly what that means, but affective behaviors that are socially constructed and therefore learned from the environment. It's not necessarily intentional. A lot of these are things that we pass on from one generation to another. There are 3 basic educational domains. You might as well put these 3 words into your mental backpack and hang on to them because they're going to come back to haunt you over and over. Those are cognitive, affective, and psychomotor. And we'll talk about these at length later, but cognitive generally refers to the hard learning of something, hardwiring something new into your brain. It can be rote memorization, such as the sky is blue, or it can be something a little more elusive, like if you give someone oxygen, you can expect their PO2 to increase. They're just bits and pieces of knowledge that you've cemented into the brain, and they become part of your way of thinking. Psychomotor, if I can skip ahead for a minute, that's the physical learning of a skill. So, for example, it would be teaching someone how to actually puncture an artery for a blood gas draw. It's the actual physical skill involved. So cognitive and psychomotor are pretty easy to evaluate. Affective, that's where it gets a little more challenging. This is more behavioral change. It's more subtle, and sometimes it is harder to measure. Learning can be spontaneous, it can be prepared. What you're doing right now is obviously prepared. But if we were in a real classroom and we could have discussions, one of you may ask me a question that would lead to a spontaneous conversation about something completely different. That's called a teachable moment, and when they show up, use them. There's some different models we can use to assess how well we've taught and or learned, and there are some other criteria that you can follow to make sure that you're doing the best possible study of the assessment changes, and also evaluating how well you're doing and creating new presentations. So the Assure model and the Glassett criteria are things we're going to talk about in a minute. The Glassett criteria you will find in the unit where you click to find this PowerPoint. You'll see that I put the Glassett criteria there too. The Assure model can be used whether you are teaching patients or teaching staff members or students. It's pretty simple. You analyze your learner, meaning you assess the situation, figure out what you need to learn. That's where you state the objectives. You let the student know, whoever the student is, whether that's a patient or another staff member or an actual student, you let them know what the objectives are. If someone doesn't know what the goals are of the end result, then there's not a real good way for them to recognize when they have learned. And when they recognize they've learned, there's a sense of accomplishment, the light at the end of the tunnel, if you will, and people are more likely to be engaged and interactive. Then you select the proper materials or methods to teach that person. You assemble those things. You teach the actual process, whatever it is. You teach the class. You talk about the patient diagnosis. You teach them how to use the MDI, whatever it is. You actually do the teaching. Then you require the learner to repeat it for you. They need to demonstrate how to use the MDI back to you, or they need to take a test. They need to do something to document that they have actually learned. And at the end, you need to wait a period of time, have the student come back, or the patient do a follow-up, have them come back later, and show you again that they still know how to do it. So you can assess whether what you did worked and if they really learned, or if they put it in the short-term memory bank, which doesn't do you a whole lot of good. As a health educator, there are a lot of hats that you wear, as the video with the girl showed you. You need to promote lifelong learning. You need to work with your patients or with your students, with your staff, whoever you're teaching. You need to work with the student side of this and ask them, how do you want to learn? If you've got younger patients, they're more likely to want to learn with interactive videos or games in a lot of cases. Older learners would they're much more likely to want a pamphlet or some sort of hard piece of paper they can take home and not use the computer as much. So you just tailor to your audience. It's really important. Encourage people to become lifelong learners and encourage them to teach themselves, but as I've said before, make sure they are savvy consumers of information. There are a lot of different things that could become barriers to teaching in the healthcare profession. Lack of time, lack of skills and motivation, most of them are probably pretty self-explanatory. You have to be able to document that you did the teaching when it comes to patient education in order to receive reimbursement from a third party, from an insurance company. In the case of educating staff or students, you have to evaluate or assess the learning in order to keep records to document that you did that. Sometimes in human resources, for example, there are mandatory things where every place in the state has to do sexual harassment training. Well, then you have to document that you did the sexual harassment training, that the people actually learned something, and you have to keep that on file. You might regularly have to go back and repeat that training, depending on state laws, OSHA regulations, and whatever other professional organizations you're dealing with. But there's someone at your hospital or at the school where you work who is in charge of telling you when it's time to do these things over again. There are some other things that are involved with this. Barriers to teaching can come in a million different forms, but probably the basic bottom line is that if someone is incapable of learning, it's usually pretty evident if you are paying attention. And if that's the case, part of your job as an educator is to try to figure out why they're not learning and overcome that barrier. Is it your method of presentation? Is it that they can't see because the light wasn't bright enough, or they need new glasses? Is it that they're frightened, they're scared? You don't want to teach a teenager how to use birth control with their parents in the room. So sometimes it's really basic stuff, but if you're not paying attention, you're going to miss what's obvious. For all the obstacles to teaching, there are twice as many obstacles to learning. They go hand in hand. You can't have one without the other. But rarely do you have a perfect situation where everyone involved is actively engaged and ready to learn and ready to teach and capable of assimilating 100% of the information that is being presented to them. I would say that that never happens. I don't think I've ever seen a situation where teachers got a classroom full of students, no matter where you are, whether it's at school, uh, whether you are a staff member at the hospital, you've got a room full of people, and 100% of the time, they are all listening to you, actively engaged, understanding every word you say. Are you kidding me? They're daydreaming. Right now, you're probably folding the laundry. There's a million other things going on. These are all obstacles to learning. Now, unfortunately, that's just sort of the nature of human beings, and so you really have to work around that. Part of the way we do that is to be sure we present information in more than one fashion, that we recap information, we do a lot of follow-ups, and that we offer people, something a little bit different. Comedy works really well. I just read recently that people learn more from Jon Stewart than they do the NBC News, so go figure.